You can go
Sure.
mute after that.
Ashok sir, Naresh sir. Naresh sir is looking like Chiranjeevi.
We are live. Yeah. So good evening, everybody, and welcome to this amazing bone school experience. And I'll hand it over to Dr. Thomas for further proceedings. Over to you, sir.
Good evening, everybody. And thank you all for logging into Bone School. For those of you who are you're attending Bone School for the first time. Bone School is a monthly orthopedic teaching program that we have been conducting since the year 2012. So this is the end of the 9th year, and happy to say that we are going into our 10th year next year. So it's been a great journey. So every month we cover a separate subspecialty in orthopedics. So we have sessions on hip, knee, shoulder, pediatric orthopedics, bone tumors, and we also conduct some skills courses. One of them is a basic surgical skills course, which includes suturing, knot tying, and things. And then we do an advanced orthopedic skills course on bone models, which includes, which gets you to play around with plates and screws and interlocking nailing. So today the session is on spine, and we have an excellent faculty here. So we have Dr. Naresh Babu from Guntur. Naresh, thank you very much for joining us. We have Dr. Ranjit Unikrishnan from Trivandrum, and we have Dr. Leela Prasad from Vizag. Gentlemen, thank you very much. It's an honor to have you here with us at Bone School, and we look forward to your lectures. I also thank Dr. Ashok and Dr. Neeraj from OrthoTV, who are helping us broadcast these sessions. The reach of OrthoTV is enormous across the world, and we have, as a result of which, we have a large number of people viewing these sessions. Thank you very much, Dr. Ashok and Dr. Neeraj. So just a few tips. So what we're going to do is we're going to have 4 lectures, one after the other. Since the audience is on YouTube, if you want to ask any questions, you will have to WhatsApp it to me. My mobile number is 9980400858. If you WhatsApp your questions to me, I can put it across to the faculty at the end of each talk. So I'll repeat that again. It's 9980400858. So thank you again. Thank you very much to the faculty. So we'll start off with the lecture straight away. And the first one is on lumbar disc herniation, and I will be giving that lecture. So are my slides visible?
Yes, sir.
Okay. So today's talk is on lumbar disc herniation, and we will be covering epidemiology. We talk a little bit about etiology and pathophysiology. We look at how to make an accurate clinical diagnosis. We look at some of the MRI terminologies that we come across on the MRI reports. We look at the natural history of lumbar disc herniation and the treatment options. So coming to the epidemiology of disc herniation, so there is a 2% lifetime chance that you may have a lumbar disc herniation. Although 80% of the population suffers from back pain at some time in their lives, only 2 to 3% of them develop sciatica. So the mean age of onset is around 35 years, and it's unusual below the age of 20 or after the age of 60. The incidence is nearly equal in males and females, although females present a decade later than males. The exact etiology is not known, although there are certain risk factors like heavy manual labor, people who are involved in work that involves constant lifting and twisting, obesity, smoking, and a family history are also risk factors for the development of lumbar disc herniation. So, contrary to popular traditional knowledge that the nucleus pulposus bursts out through the annulus, this study from Coimbatore, from Ganga Hospital has shown that a majority of disc herniations occur due to a failure at the end plate junction here. So it's only 35% of cases where the nucleus pulposus ruptures through the annulus and comes out. But in 65% of the cases, it's a failure at the end plate junction here, and a small part of the end plate breaks off and then the disc herniates out. That is something to remember. The other one is what causes the leg pain. So it's important to remember that the disc itself is a avascular structure, and when the disc comes out of its normal place and comes in contact with the body's immune system, the body doesn't recognize those proteins, as a result of which there is an intense inflammatory reaction. So the mechanical compression on the nerve root plus the inflammatory reaction, where there are interleukins, TNF alpha molecules, there is TNF alpha. So all of them together cause this intense inflammatory reaction close to the nerve root, and that is what causes that leg pain in following lumbar disc herniation. So to make a diagnosis and treat this appropriately, you need to have good clinico-radiological correlation. So the symptoms, the signs, and the imaging. So the symptoms of pain down the leg, the signs, predominantly neurological signs that you can pick up on examination, and the imaging should correlate for you to make a right diagnosis. And that is the key to a successful outcome. So the symptoms of lumbar disc herniation typically are pain radiating down to the lower limbs, may or may not be associated with back pain. There may be numbness and weakness in the legs, and rarely there may be bladder dysfunction in the form of retention and overflow, incontinence. So it's important to remember that when you say lumbar radiculopathy, you're talking about pain that goes in the distribution of a specific nerve. So the pain usually travels down in the dermatome of the affected nerve. So if there is an S1 radiculopathy, the pain is in the S1 sensory dermatome. So that is the back of the calf and the lateral aspect of the foot. If there is an L5 radiculopathy, the pain is typically on the outer aspect of the calf and maybe the dorsum of the foot. An L4 radiculopathy is on the inner side of the leg, and an L3 radiculopathy is the front of the thigh. So it's very important to remember this, because the distribution of pain should correlate with what you see on the MRI. Okay, so don't get fooled by pain that goes into the buttock or the back of the thigh, irrespective of what the MRI looks like, because it may be just referred pain from some structures in the back, most commonly the facet joints or the sacroiliac joints. So for you to call the pain radicular, it means it has to come from the root, and hence it will be felt in the dermatome of the affected nerve. So that is different from referred pain, and this is radicular pain from the nerve root itself. The common tests we are all aware of, there is the SLR, there is the neurological examination, and we'll come into that. So a straight leg raising test is conducted with the patient lying supine, the knee extended, and the hip flexed. It is an assisted test. It's a passive test, and if it reproduces the patient's leg pain, it is a positive test. So an SLR that causes increased back pain is not a positive SLR. So for the SLR to be positive, it should reproduce the patient's leg pain. And the pain occurs because you're stretching an inflamed nerve. The second one is the crossed SLR, or the well leg raising test, wherein the patient, in this case, if the patient has got pain running down the left lower limb, and raising the right lower limb may cause increased pain in the left lower limb. Now that is called the crossed SLR, or the well leg raising test, which is more specific than the standard SLR test. The third one which we want to discuss is the femoral stretch test. So now the SLR actually tests the lower lumbar nerve roots, whereas the femoral stretch test tests the upper lumbar nerve roots. So for this, the patient lies prone and with the hip extended. If the knee is flexed and the hip is extended, if you can reproduce the patient's pain in the thigh, that is referred to as a positive femoral stretch test. So those are the basic tests. I won't go into the neurological examination. I hope most of you know how to do a quick neurological examination of the lower limbs, including motor, sensory, and reflexes. There are a few things that you need to remember when you're looking at lumbar discs and which nerve root is affected. And there are a few simple things that you need to remember. So if you go down from the cervical spine, you know that the C1 nerve root comes out between the skull and C1. The C2 nerve root comes out between C1 and C2, and that goes on till you reach the C7 T1 level. So above C7 is the C7 nerve root. Between C7 and T1, you have the C8 nerve root. And from then on, the nerve root that exits between two vertebra is the number of that nerve root corresponds to the number of the vertebra above. So between L4 and L5, the nerve root that exits out is the L4 nerve root. But the disc herniation is typically a posterolateral disc herniation that occurs over here. And the nerve root that gets compressed is actually not the nerve root that's going out or the exiting nerve root, but the nerve root that is traversing that disc, or the nerve root that is traversing that disc. That's the L5 nerve root. So when you're talking about an L4, L5 posterolateral disc herniation, it is typically the L5 nerve root that gets involved, unless of course you have a disc herniation which is right out here called an extraforaminal disc herniation, which may pinch the exiting L4 nerve root. So that is something that you need to remember, so that you can correlate your clinical findings with what you see on the MRI scan. Now, the imaging modality of choice to diagnose lumbar disc herniation is a plain MRI. And this is the American College of Radiology appropriateness criteria. So they've given it a score of 8 out of 9. So yeah, plain MRI is the imaging modality of choice to make a diagnosis. On the MRI report, you normally see numerous terminologies. So I'll just go through some of the common ones that you will see. So if you take an axial section of a vertebrae on the MRI, you will see that the disc and this is at the level of the disc, you see in a normal disc, the posterior aspect of the disc is concave, like this. So in a normal disc, there is no extension of the disc beyond the interspace. A disc bulge, on the other hand, is a circumferential. So it involves the entire circumference of the vertebrae. It is symmetrical, so equal on all sides. So circumferential symmetrical extension beyond the interspace. So there's loss of that concavity. It becomes convex. That's called a disc bulge. And the next three terminologies together can be called disc herniation. But herniation could be a protrusion, it could be an extrusion, or it could be a sequestration. Now, these are, as opposed to a disc bulge, which is circumferential, this is more focal. So it is only in one area of the disc. And in a disc protrusion, the nucleus material remains within the outer fibers of the annulus. So it does not come out completely. A disc extrusion, on the other hand, is when the nucleus has penetrated the outer annulus and come out beyond the outer annulus. And a sequestration is when a fragment of the disc has broken off and is not in continuity with the rest of the disc. So that's a disc sequestration. Okay, so these are common terminologies that you come across on MRI reports, and it's worthwhile knowing them. So the next thing that we talk about is the natural history of disc herniation. What happens to disc herniations if you don't do anything? So disc herniations were actually described many years ago by Hippocrates. And although he did not know the exact cause of the radicular pain, he thought it was a subluxated hip, and hence the name sciatica, which comes from the word ischios, meaning hip. He found that in a majority of people, the pain settles down within 40 days. That's around 6 weeks. And the treatment that he advocated was warm water application and fumigation and laxatives and even donkey's milk. So even with donkey's milk, he said that most of them will get better within 6 weeks. So more recently, studies have shown that this is Weber's study from 1993, shown that a majority of patients have complete resolution of the symptoms with time. And this was a comparative study between two groups, 140 patients who had surgery versus 142 who were treated non-operatively. And by 12 weeks, there was no difference between the two groups. So they came to the conclusion that early surgery with the aim of minimizing the risk of long-term disability is not justified. So the other thing that prompts people to advise surgery is the size of the disc. They say patient's got a massive disc herniation. But we know that the morphological changes of herniated mass correlate well with the clinical outcome. So sequestrated and transligamentous extrusions actually get absorbed or resorbed quicker. So, and this study found that 88% of the cases showed a reduction in the herniated mass on MRI. And if they're larger discs, transligamentous, so like your disc extrusions and disc sequestrations actually get resorbed much quicker. And this is because the inflammatory reaction, the cells that come in actually cause the discs to be resorbed completely. And the extent of the inflammatory reaction is also more in the sequestrated and the transligamentously extruded discs. So these get resorbed much faster. So just the size of the disc is not an indication for surgery. Okay. Cauda equina syndrome is the other thing. So we talked about three kinds of symptoms that people have. One could be the leg pain, one could be the numbness and weakness in the leg, and the third one is the cauda equina syndrome, predominantly a bladder dysfunction, and the patients present with either retention of urine or overflow incontinence. So this is an indication for urgent surgery because it has been shown that significant recovery in motor sensory deficits and urinary function occurs in patients who undergo surgery within 48 hours. So there are very few absolute emergencies in spine surgery, and this is probably a cauda equina syndrome caused by a lumbar disc herniation is probably one of them. Okay, so what are the indications for lumbar discectomy? So the indications are failure of symptoms to subside following a reasonable period of non-operative treatment. And what is a reasonable period of non-operative treatment? The reasonable is probably around 6 weeks. And we go back to what Hippocrates said. He said, you know, most of them get better in 40 days. So that's around 6 weeks. So if patients don't get better in 4 to 6 weeks or 6 weeks, then we start thinking about the surgical options. Unless the patient, the second indication for surgery is if the patient presents with a significant or a progressive neurological deficit. And the third indication, progressive motor deficit, sorry. And the third indication is the cauda equina syndrome, which like we discussed earlier, is an absolute indication for surgery and early surgery. So coming to the surgical options, you have three more commonly done options. One is a standard microdiscectomy, wherein you expose the lamina on one side of the spine, remove a portion of the lamina called a laminotomy and remove the disc. So that can be done with or without a microscope. The second one is a discectomy using a tubular retractor. So there's less paraspinal muscle damage with that. And the third one, which uses an even smaller incision, is an endoscopic discectomy. The outcomes of all these are the same. The difference is the amount of soft tissue or paraspinal muscle damage that you cause during the surgery. What are the non-operative measures? Now we know that a majority of them get better with time. So it's important to know what non-operative measures work rather than using some traditional or time-tested methods which have got no evidence at all. So these are the common things that people or commonly use non-operative measures, and we'll go and look at the evidence of each one of them. Number one is bed rest. So we see a lot of patients coming who've been advised to rest in bed for weeks at a stretch. So it has been shown in this Cochrane review that there is little or no difference between bed rest and staying active as far as recovery from sciatica is concerned. So most of the time what we tell our patients is that they can walk around inside the house and do things within the limits of their pain. Number two is traction. So there is hardly any role for traction in any spinal condition. So there is very little evidence that it works. It used to be very popular in Hippocrates' time, and I think it's time that we let it go. Physiotherapy and exercises for lumbar disc herniation, there is an insufficient evidence actually to make recommendation for or against the use of physical therapy exercises, although a lot of physiotherapists use maneuvers to try to centralize the pain, so to make the pain recede from the legs and then concentrate it on the back alone. I personally don't send my patients for physiotherapy for lumbar disc herniations. Electrotherapies in the form of shortwave, ultrasound and TENS really don't work. So there is no evidence that these have any role in lumbar disc herniation. Medications, NSAIDs is definitely the first line of treatment. There is no evidence that one NSAID is better than the other. Some people give oral steroids. They do provide short-term relief. Anticonvulsants like gabapentin and pregabalin have become very popular for most kinds of nerve-related pains. And amitriptyline also helps with neuropathic pain. So there's an antidepressant group. Fluoroscopy guided steroid injections have been shown to provide good relief of pain immediately, and there's good evidence to support it. And it has sort of become the standard of care for treatment of lumbar disc herniations early on. So in conclusion, non-operative treatment has a role because a majority of cases of lumbar disc herniation resolve spontaneously with time. Bed rest and traction are not effective treatment modalities. A transforaminal nerve root block gives good early relief of pain, and failure of non-operative treatment is a significant indication for surgery. And like we mentioned before, surgery could be either a microdiscectomy, it could be done through a tubular retractor, it could be done through an endoscope. The outcomes are the short to long term outcomes are nearly the same. So that is the end of my talk. And if there are any questions, please feel free to WhatsApp it to me. But while these are coming up, I'll request the next speaker, Dr. Leela Prasad from Visakhapatnam, to deliver his lecture on spondylolisthesis.
Thanks, Thomas. Am I audible?
Yes, you are.
Shall I start sharing my screen?
Yeah, while you're sharing it, I'll just answer some of the questions.
Okay.
So one of the questions that has come up to me is history taking wise, any way to differentiate between IVDP from other spinal pathologies? I think no, IVDP is predominantly a shorter duration, and the pain is typically in the dermatome of the affected nerve. And if you have an acute IVDP, you typically will have a positive SLR. So those are the things that I can think of. But any sudden onset compression on the nerve can also cause radiculopathy. So that's something that you need to remember. Okay. Thanks. Leela, can you go ahead with your talk, please? Thanks.
Can you see my screen?
Yes, we can see your screen.
Shall I start? Yeah.
Yes, please. Just put it on full screen, Leela.
Yeah, thanks, Thomas, for the opportunity, and thanks, OrthoTV. Well, topic given to me is lumbar spondylolisthesis and lysis. Okay. So basic outline of my lecture would be classification and grading of listhesis, the common clinical presentation, indications for surgery, the various surgical options available, and a few slides about the surgical technique. Interestingly, spondylolisthesis, the term was coined by a gynecologist in 1854. He described this due to gravity and posture. Now, this is coined from a Greek word, spondylo meaning vertebra and listhesis meaning to slip. So and grading was given by Mayer Ding. So the grade, this is how it is graded. The upper end plate of S1 is divided into 4 equal parts, and the grades are based on the amount of slip of the L5 vertebrae over the S1. So the slip is less than 25%, it's grade 1. 25 to 50 is grade 2. 50 to 75 is grade 3. Grade 4 is more than 75. If the L5 is totally off S1, then it is termed as Spondylolisthesis. Now, classification. The earlier slide was about grading of listhesis. Now this is classification. Classification was given by Wilsey. This was based on the etiology of the listhesis. So these are basically 6 types. Type 1 is dysplastic. Sorry. Type 1 is dysplastic. Type 2 is ischemic. Type 3 is degenerative. Type 4 is post-traumatic. Type 5 is pathological. Type 6 is iatrogenic. So type 1 is dysplastic. This is the true content. There is malformation of the facets of the articular facets of the L5 and S1. Because of this malformation, the L5 facets, they subluxate over the S1, and these are associated with spina bifida in most, about 95% of cases. These type of listhesis have high incidence of neurodeficits. They tend to present with a scoliotic-like deformity. There is local kyphosis at the lumbosacral junction. They have a couched gait because of the hamstring spasm. And there is gradual attenuation of pars. However, there is no frank gap or defect in the pars. They tend to progress rapidly. Fortunately, they are very rare. The next type is the type 2 or the ischemic type. This is the most common type. Here there is a defect in the pars. Now, what is pars? Pars is a part of the vertebra located between the inferior and superior articular process of the facet joint. In the transverse plane, it lies between the lamina and the pedicle, and this portion can resist significant forces during normal motion. So this is the pars, the portion between the superior and the inferior articular process, and in the axial plane, it is between the pedicle and the lamina. So this is the defect you can see here. This is the pars defect. So this is the pars seen on the lateral view. The portion between this is the superior articular process. This is the inferior articular process. The portion between this is the pars. Now this is the oblique view. You must have heard of the Scotty dog sign. Sorry. So this is the Scotty dog. This is seen on the oblique view. This is the pedicle. This resembles the eye of the dog. This is the transverse process. Resembles the snout of the dog. This is the superior articular process, which resembles the ear. This is the inferior articular process, which resembles the forelegs of the dog. The spinous process resembles the tail, and the contralateral inferior articular process resembles the hind legs. So this is the famous Scotty dog appearance, and pars is this portion, the collar of the dog. So if there is a break in the pars, this appears as a beheaded Scotty dog. Now in type 2, there are about 3 types. One is the lytic. The subtype A is the lytic. This is most common in younger patients. In patients less than 50, the most common type of listhesis is lytic listhesis. Now this lysis is due to repeated biomechanical stresses, repeated microfractures. It could be either due to heavy work or sports. Because of this repeated microfractures, there is a stress fracture. There is a complete fracture within the pars, and this fracture fails to heal. This is because of hyperextension and overuse of the back, especially common in gymnasts, weightlifters, volleyball players, and football line. And high levels of activity during childhood are associated with higher incidence of development of pars defects. Subtype B is an elongated pars. Here also there is, this is caused by microfractures of the pars. However, the pars does not fracture completely, and there is healing of the microfractures, and it heals in a stretched position. So this longer pars is an elongated pars, causes the vertebra to slip forward. The subtype 3 is a very rare occurrence. It's an extremely rare condition. This is due to acute pars fracture in a trauma. It commonly occurs in a hyperextension injury. This is very rare. And type 3 is the degenerative listhesis. Degenerative listhesis is common in elderly, more than 50 years of age. Now this starts off with the degenerated disc losing its elasticity, and once the disc is degenerate, it places greater stress on the facet joints, and then they are subjected to shear forces. They become hypermobile, and then they become incompetent, and hence the upper body moves forward. They are commonly associated with the lumbar canal stenosis and degenerative disc disease. However, they do not progress beyond grade 2, and it's more common at L5, L4-5. Unlike lytic, which is common at L5S1, degenerative is more common at L4-5. So degenerative listhesis is associated with this severe lumbar canal stenosis and a black disc. Type 4 is traumatic, similar to type 2C, but the fracture is any other part of the vertebra other than pars. For example, could be facet joints. Type 5 is pathological. It could be either due to localized conditions like tumors or infection, or any generalized disorders, which weakens the bones and causes fractures, leading to instability and a potential slip. Type 6 is iatrogenic, that is surgeon-made condition. This is due to overzealous resection of the pars or facets. It causes instability and the upper body slips forward. To summarize, spondylolisthesis can be caused by a birth defect that is congenital, could be caused by spondylolysis due to degeneration, trauma, tumors, or surgery. Clinical presentation. Many people with listhesis are symptom-free, and in fact, in most of the cases, it's incidental finding. When an X-ray is taken for some other condition, you pick up the listhesis, and only some portion of patients have symptoms. And even most patients who have symptoms, they have symptoms on and off. They get symptoms, they get better. Maybe after a few years, they get again symptoms. So very rarely patients are severely symptomatic. Symptoms is basically back pain and leg pain. So back pain is typically they get up pain when they get up from sitting position. So they hold their back and they get up, the typical extension catch. They may get pain while turning in bed. They get pain while loading the back. For example, if they lift weight, they tend to get back pain. And the leg pain could be either in the buttocks or in the thigh and leg. And typically, this leg pain would increase on walking and standing. This is the claudication. And pain is relieved with sitting, lying down, or stooping forward. And very rarely, you may get impairment of bowel and bladder functions. This is the classical shopping cart sign. So after prolonged standing or walking, if they get pain, the patients tend to lean over the shopping cart. So when flexion increases the canal of the size of the spinal canal by stretching the buckling ligamentum flavum, reducing the overriding lamina, that's how it enlarges the foramina. So that's how it relieves the pressure on the exiting nerve roots and thus decreases the pain. Signs. We can palpate a step off in the lower lumbar area in grade 2, grade 3 slips, and all these signs are of lower motor signs. There may or may not be motor sensory deficits. Ankle jars may be diminished or absent, and hamstring muscles usually tight, right? And the walking, they resemble waddling movements. And in high grade slips, they may have a protuberant abdomen. Investigations. MRI, of course, is gold standard for all spinal conditions, but to pick up a lysis or a listhesis, MRI may be inadequate. So, for example, see this patient. He has been suffering for the past 2 or 3 years. He has been going around many doctors, and so this MRI is apparently normal. There is no compression on the chordae equina. The discs are reasonably healthy. The discs are wide discs, so there is no compression. There is no obvious listhesis as well. This is the MRI. However, see the X-ray. There is a definite lysis of the L4. So MRI usually does not pick up this lysis unless a very trained radiologist can pick up. For a common orthopedic eye, it's very difficult to pick up lysis on an MRI. So for all patients, you should get an X-ray of the back. And this is the oblique view. We can visualize the pars clearly, and pars defects can be visualized clearly on an oblique X-ray. And this is the flexion dynamic X-rays, flexion extension X-rays. They demonstrate any abnormal mobility. And you can see this radiolucent thing. This is the vacuum sign usually seen on the dynamic X-ray. This indicates instability. And the good quality X-rays are important. For example, in this X-ray, both X-rays are of the same patient. You can hardly make out the lysis here, whereas in this X-ray, the lysis is very clear. So you should make it a point that your X-rays are very clear. AP views are also very important. See, in this is a lateral view. The lysis is very obvious in this. However, should always get an AP view. So in the AP view, you can see this spina bifida and hypoplastic lamina. So if you were to jump in this for surgery, you would land up in big trouble. So if you don't notice this deficient lamina. So AP is always essential. MRI, the important thing is the listhesis would be seen here. Grade 2 and all can be identified on MRIs. And the important aspect in MRI, should always get a whole spine screening, because we never know what is happening above in the dorsal spine and the cervical spine. There may be tumors of cervical compression or dorsal compression. So make it a point that you always get a full spine screening. And fortunately now we get these 3 Tesla machines are available everywhere. This was about 10 years back. This was an apparently normal looking MRI. However, this turned out to be this was done on a 0.25 Tesla machine. However, this turned out to be a intradural tumor. So make it a point that you should always have a good quality MRI. CT scan picks up lighting defects very easily. So you can see this lighting defect on the axial views and on the coronal views. So if any doubt about the lysis, you can always get a CT scan. But routinely, you don't need a CT scan. Case selection. Once you pick up a case of spondylolisthesis, do all cases require surgery? The answer is a strict no. So it all depends upon the duration of symptoms and the severity of symptoms, and to an extent grade of the grade may not be in all cases. The grade of listhesis may not correlate with symptoms. For example, a grade 1 patient may be having severe symptoms, or maybe a grade 3 patient may or may not be having symptoms. So grade will not always correlate with the severity of symptoms. And to decide if the patient needs surgery or not, you should take this into consideration: the duration and severity of symptoms, and failure of adequate conservative treatment. As a basic thumb rule, inability to do his activities of daily living or inability to go to work for more than a few months in spite of adequate conservative care is a safe indication for surgery. And non-surgical care, you can give short periods of rest. Prolonged bed rest is of no use. Medication, as Thomas told, you can give anti-inflammatories, steroids, gabapentin, all those things. And the modification of activities. Some elderly patients, they are happy to modify their activities and to avoid surgery. Physiotherapy would help to a certain extent. Epidural steroids, especially in degenerative listhesis. Epidural steroids and root blocks can relieve the patient's symptoms. Before operating, it's very important that you should be doubly sure that the symptoms, the back pain and or the leg pain, are solely because of spondylolisthesis, and they are significantly disabling and of significant duration, and the patient has tried all the other measures. So if all the other measures have failed and the symptoms are solely because of spondylolisthesis, then only you should proceed for surgery. This is an example. The patient had 2 months of severe left buttock pain. She was hardly able to walk and stand. So this patient was actually referred for surgery. You can see the grade. This is a lytic listhesis of L4-5, grade 1 bar 2. You can see in the MRI also listhesis. However, I've asked for an MRI of the pelvis eclipse. You can see the left-sided sacroiliitis. And then this turned out to be tuberculosis sacroiliitis, and this is after 9 months of AKT. This has resolved well. So before putting a knife, just always check for other causes. This is again 2-level degenerative listhesis. An elderly lady. She happened to have an arthritis of the hip. Okay, in the counseling, before taking up a surgery, the expectations of the patient should be realistic. I should tell him that surgery is not a panacea for all his problems. Surgery is for pain relief, to improve his quality of life, neurodeficits, if the patient has neurodeficits, they may or may not improve. Principles of surgery: decompression, stabilization, reduction, fusion. Then if disc is the pain generator, removing pain generator and restoring normal loading through the disc. Surgical options are many: decompression alone, Gill's excision, pars repair, intertransverse fusion, and interbody fusion. And there are many varieties of interbody fusion. Decompression alone has very limited indications, especially in a degenerative spondylolisthesis. In grade 1 listhesis, there is no abnormal mobility on dynamic X-rays. There is no movement inflection extension X-rays. And the principle here is adequate decompression should be done without removal of excessive bone, without destabilizing the facets. It can be done microscopic, endoscopic, or open. Gill's excision was done earlier. The rattler used to be removed. This is had only short-term results. Leg pain was related to some extent. However, it was very easy to perform. And then there is no fusion. It doesn't address the back pain and instability. So nowadays, this is no longer being done. Pars repair can be done if there is, especially in young patients, if there is a pars defect and there is no listhesis, you can attempt pars repair. You can attempt direct bugs repair. You can put in a screw, megaral screws, or you can put in pedicle screw in the upper body and put in hooks, sublaminar hooks. So this is how you can, this is how you can preserve the intervertebral disc. Uninstrumented fusion, again, it is obsolete. Without instrumentation, fusion rates are very less, and it requires prolonged immobilization. Implants, now these gold standard is pedicle screws. Earlier, Hartley rectangles were used, but again now they are obsolete. So you see for an L5S1 listhesis, the instrumentation is from way above from L4. It's coming down all the way here. So for so standard of care here now is pedicle screws. Pedicle screws allow for segmental fixation. Coming to intertransverse fusion, where you place bone grafts between the transverse process. Bone grafts are placed between the transverse process and put in screws and they fuse. They are allowed to fuse. Here they can the roots are decompressed, the instability is addressed. Since this is instrumented fusion, you get better fusion rates. Short-term results are good. However, technical difficulties here. While exposing you have to expose the tips of transverse process. There are a lot of bleeders here, a lot of bleeding here, and preparing bed for the for fusion is very difficult. In most Indian patients, the transverse processes are very small and hypoplastic. They tend to fracture very easily. And once you do a decompression, if you remove the posterior elements, there is very little less bed remaining for fusion, very little surface area remaining for fusion. And moreover, it is biomechanically inferior. The fusion mass is inadequate, and there is no anterior column support. So there is a lot of stress on the posterior implants, and they may ultimately break. Interbody fusion is much better than intertransverse. There is better environment for fusion. The graft is placed in the interbody area. This interbody area is it is the load-bearing area. 80% of the load is comes through the interbody area, whereas only 20% comes through the posterior. And it allows to restore the lordosis, allows for coronal reconstruction. You can put in, you can distract the disc space. You can restore the height of the disc space. And by restoring the height, the foraminal volume is also increased. So it allows for indirect decompression. And once you remove the disc, so the pain generator disc is removed, so there is more pain relief. Posterolateral fusion in a degenerative disc places a lot of stress on the posterior implants, whereas if you put a spacer, there is less stress on the implants in interbody fusion. I see the overhead view. So this is the surface area available for fusion and interbody fusion. You can see this. And for an intertransverse, this is the surface area. So this is much more than the bed available for intertransverse area. However, it is technically challenging. It takes much longer time than intertransverse. Complications are many, injury to the roots and dural retraction, and it may be too rigid. And coming to the types of, I'll go through this fast. Coming to the types, the PLIF, that is the posterior lumbar interbody fusion, where the dura is retracted from both sides, and you put in graft from both the sides. So this involves a lot of dural retraction, and hence there is more chances of injury to the dural sac, the thecal sac. So a lot of dural injuries and injury to the nerve roots. So now the T-leaf has come up. This is basically a unilateral approach. There is less retraction of the nerve root, less dural taste, less neuropraxia. Revision becomes easier. It can be done by open or MIS. So as of today, T-leaf is the gold standard for spondylolisthesis. Surgical procedure under GA, infiltration, subperiosteal section. So positioning is prone position, abdomen is free. So the transverse process, the base of transverse process are exposed. First you put in the screws. These are the pediculars. You can use a C-arm or you can do a freehand. This is the sounding probe. Tap. So once the 4 screws are put in, then you proceed to the decompression. So this is how the screw should look like in an axial views. The screw should be converging, and they should be within the pedicles, and they are just short of the anterior border of the vertebra. And decompression, if you are doing a lytic listhesis, you can exercise the lateral, the rattler. The exiting root should be decompressed, whereas in a degenerative listhesis, the traversing roots are decompressed, and you can either do a fenestration, laminectomy, or laminotomy for decompression. So this is the where you enter the disc space in a T-leaf. You remove the facet, so you are quite far away from the nerve root. So this is your entry working zone. So you are away from the nerve root. This is your working zone. You are away from the exiting and the traversing roots. So a lot of epidurals over here. You should use a bipolar to coagulate epidurals, do anelotomy and then do discectomy. These are the angled curettes. So with these angled curettes, you can go to the opposite side and remove the disc. So this is the disc material removed. Nowadays, I sometimes do it from both the sides. This is from one side and this is from the other side. Once the disc is taken out, you should try to do, jack up the disc space with the serial dilators. And while you are putting this dilator inside, your assistant should retract the nerve roots. Once the discectomy is done, a cage packed with graft is inserted. And then the disc space is packed with bone graft, which are inserted through a funnel. Your disc should go to the anterior 2/3 of the interbody space. So this is how it looks in the CA. And wound is closed and drains. So this is how your post-op X-ray should look. Okay, so I think I'll skip this. This is a lytic listhesis. You can see the disc space is almost collapsed, and in the post-op, the height of the disc space is restored. The local kyphosis is corrected, and this is about 2 years post-op. You can see the fusion. This is another patient who earlier underwent Gill's excision, and the symptoms recurred. Then T-leaf was done. So this is the midline dural. This was not disturbed. So entry is from the lateral side. So very safe procedure even for revision cases. Now coming to other types, ALIF is you approach the disc from the anterior side. The advantages being you have a direct view of the disc space and the vertebral bodies. You can it permits the easier clearing of the disc space. The posterior muscles are spare, so you have less post-operative pain. Disadvantages: you have to go through major organs and blood vessels come in your way. Prior abdominal surgeries or scars are a hindrance. The high incidence of retrograde ejaculation, and as orthopedic surgeons, we are less familiar with this approach. So the disc is removed from the anterior and put in bone grafts are packed or cages. Axe-lift is another new technique, whereas a guide wire is inserted through the presacral fascia behind the rectum. Now it goes into the sacrum, and from there it goes into the L5 S1 disc space and to the L5 body. And you pass in serial dilators, and then you remove the L5 S1 disc through this. This is restricted only for L5 S1. X-lift is direct lateral approach. This is a trans-OS approach. This high incidence of post-op weakness of flexors, and it requires neuromonitoring. OLIF is now recently gaining popularity. Effective anti-interbody fusion. This offers indirect decompression, offers rigid stability, correction of the alignment. It restores the lumbar lordosis. And unlike XLIF, it is a non-psoas splitting approach. It's indicated for degenerative listhesis, scoliosis, less incidence of neurodeficits. This is how it goes. You go as a retroperitoneal approach, go anterior to the psoas. You approach the disc space, take out the disc, and put in bone grafts. So this is the final X-ray. And Thomas, do you have some time to reduce or not? This is the only condition in orthopedics where a few more slides, Thomas.
Yeah. Sure. Go ahead.
Yeah, reduction. This is a controversial issue whether to reduce or not. The only situation where the surgeon can consider not to correct an advanced symptomatic deformity. The advantage of the reduction is stops progression, lessens the postoperative pain, permits full decompression, promotes union, and restores posture. And the for example, in a long bone, if the reduction is good, the chances of healing are more. If the reduction is bad, the contact between the fracture surfaces is poor, then the chances of union are poor. Similarly, in listhesis, if your reduction is good, the chances of union are good. Then the other advantage is quality of fusion is optimized. If reduction is not performed, there is smaller surface area available for fusion. When the slip is corrected, we have more surface area for bone grafting. And however, the reduction has its own flip side. There's high incidence of risk to the L5 nerve roots, about 70. If you try to reduce fully, there's the chances of nerve root injury are very high. So what we do is try to reduce the disc slip only by 1 or 2 grades, not the complete reduction, but you do a partial reduction. So you have the advantage of more surface area, restoring the anatomy, and avoiding the chances of nerve root injuries. In situ fusion for low grade listhesis, in situ fusion is totally fine, whereas in high grade listhesis, the technique is more prone for non-union and subsequent progression of the listhesis. So in high grade listhesis, you always try to reduce at least 1 or 2 grades. For both low grade and high grade listhesis, in situ fusion, it runs contrary to the principles of restoring physiological alignment and balance. And it may have long-term implications on adjacent segment disease. However, there are studies pseudoarthrosis rates for in situ fusion are high. For in situ fusion are high. However, if you reduce and fuse, the chances of fusion are higher. However, there is no significant difference in clinical outcomes in patients treated with in situ versus reduction. Thanks, Thomas. If there are any questions, I would. Any questions now? Or
yes. Yeah. Thank you very much, Dr. Leela Prasad, for that excellent lecture. You have some questions come up for you.
Yeah.
Number one is, does listhesis progress in adults?
Yeah, if it is degenerative listhesis, I've told degenerative listhesis are very unlikely to progress. Lytic listhesis, more than grade 2, the lytic listhesis may progress, and dysplastic listhesis is more prone for progression. Degenerative listhesis, the least likely. Lytic listhesis is also less likely. Low grade lytic listhesis. Dysplastic listhesis is more prone for progression.
Thank you. There's one more question. When would you do a pars repair as opposed to a fusion?
Yeah, pars repair, especially in young patients. If you're fused, you are losing one mobile segment. So especially in young patients, if there is no listhesis, and if the disc is well hydrated, if there is a black disc, I would not go for pars repair. If there is a listhesis, I would not go for pars repair. So ideal candidate for pars repair is a well hydrated disc without any listhesis, with only lysis and back pain.
Thank you very much, Leela. One last question, and I think I'll open it up to all the faculty. There's somebody who wants to know how do you manage So if somebody wakes up from a spondylolisthesis surgery following a high-grade listhesis reduction and develops urinary retention, how would you manage it? So, Ranjit, can I start with you, and then Naresh? Somebody has asked a very specific question. How do you manage post-op urinary retention? So I think they're looking at not, just a neurogenic bladder or a bladder nerve injury following high-grade listhesis reduction. What would you do?
Is a question to me,
Yeah,
Thomas?
Ranjit. Yeah, I mean, anybody from the faculty can.
Okay. So for me, any high-grade listhesis where I am planning a reduction, I always document the bladder status pre-op. The most simple thing is I see for post-void residual urine. I always document that, number one. Number two, I significantly, specifically ask for bladder instability symptoms. I ask them, even though they might not complain, I ask them, do you have frequent urination? Do you have incomplete urination? And I always document that. And I tell them that there's a very, very high possibility that you might be on a post-op catheter for long. So they already know that. I kind of consent them that you might be on a catheter for long. I will try one attempt of voiding after 24 hours of surgery when you start walking. And at that point, if you cannot void, I'll put you back on the catheter for 6 weeks. And at 6 weeks, I'll attempt a removal. Because I already tell them that you can new for me. I always tell them that you might be on a bladder, especially high-grade dysplastics ones, which are the ones who have got S1 and S2 instability. So I kind of plan for it. So there is nothing new of not me finding it new. I tell them you will have it most likely. So the ones with no, with less than 50 ml of post-void residual urine, it's very very unlikely that they will have a retention post-op unless I have damaged the root. If I have damaged root, I can know it intraoperative that I've messed with the root and they're going to have it. And I tell them that I had to manipulate your root. So you might have a bladder issue. And most of the times they recover by 6 to 8 weeks time.
Thanks, Ranjit. Naresh, anything more?
Thomas, that's a very tricky question. I think we understand.
Sorry, it came in from somebody from.
I
won't
got
give you
it.
the name from Andhra, I think.
So our Andhra guys are very tricky. First thing is, patient can't wake up with bladder retention because all these surgeries are done with under catheterization. So you have should be catheterized.
Yeah, so I think what they meant was retention
develop,
after removing catheter.
Yeah, after catheter. That's what.
After catheter removal, there are 2-3 ways how this develops. One is like Ranjit was mentioning, high grade slips where you fail to document pre-existing subtle bladder symptoms, and then your dural interaction will lead into that kind of a problem. Second thing, that is a complete different scenario. High grade listhesis with pre-existing potential cardiac venous syndrome developing into full-blown cardiac venous syndrome post-operatively is a different thing. But most of the times when these things happen, they happen when you are especially doing for L5S1 and you damage lower sacral roots. Incidental durotomy if it happens, and then the few of the sacral fibers from S2 down, if they get injured, that is one possibility where these things can happen, but they will recover eventually over a period of time. If that doesn't happen, like you will give an attempt of voiding urine post-operatively, as Ranjit said, at day 2. If that doesn't happen and the patient needs to be catheterized, that is the time where you continue the catheterization. Post-operate only at the time of suture removal, if still patient can't pass urine, then you need to go for this bladder neuro symptoms of bladder function, establishing the neurological bladder. That is a completely different scenario. This is a possibility even in disc surgery when there is a midline dural tear and the root fibers which come out are the sacral roots. There is a issue of patient won't have neurological deficits, but they have some kind of bladder issues. So that's why the precautions to avoid these things is to don't retract the thecal sac more than 50%, a dural sac more than 50% while doing any kind of lumbar surgery. And of course, for above L1, no for any kind of dural retraction for more than the CSF column. And then whenever you have a dural leak, incidental dural leak or identified dural leak, try to repair them or cover them well. Otherwise, these patients will develop this kind of deficits. I have seen few patients, and then I was called for intraoperative surgery when they had an issue to repair the dura. By the time I went, the surgeon has actually closed the dura, but you can see few fibers were caught in between the sutures. So those were the sacral fibers. If those something like that happens when you are not very careful in suturing, the fibers putting them back, patients can have persistent neurological bladder defects. That's my personal little experience in this.
Thank you, Naresh. I think we'll go on to the next lecture, and I invite Dr. Ranjit Unikrishnan from Kim's Hospital, Trivandrum, to give the next lecture. Dr. Ranjit will be talking about tuberculosis of the spine.
Can you see my screen, Dr. Thomas?
Yes, we can see your screen and you're audible also. Just a little louder, if you don't mind, Ranjit.
Yeah. Okay, is it better?
Yes, better.
Okay, fine. Okay, thanks, Thomas. Thank you very much. Glad to be with the Bone School. This is our TV spine. It's a very long lecture, so we'll try to keep it focused to the residents, and so what we should learn, because that's what Dr. Thomas told is to be emphasized. So we know that today TB spine is a medical disease. With the current ATT and current imaging modalities, it's a medical disease. So as orthopedic surgeons or spine surgeons, when we treat them, the idea is a paradigm shift from prevention of mortality, which was common in the late 60s or early 50s, to prevention of deformity. So that should be very clear when we start treating them. It is prevention of deformity. We know that most of the time tuberculosis TB is a most common form of skeletal TB, accounts for 88% of the chronic vertebral infections. 30% of them occur before 10 years of age. Vertebral column affection occurs due to a hematogenous dissemination from a primary infected organ. So we should always remember that it is secondary. The primary focus may or may not be active or may be quiescent. So search for primary is not always very fruitful. We know the classical pathogenic picture. So these pictures are useful for your exam answers, where you can just illustrate this, how it starts, how it comes, how it spreads, gets you more credit when you when you draw these pictures. So why it is paradiscal? Because classically it was thought as paradiscal because it is simultaneous involvement of paradiscal parts of two contiguous vertebrae is a most typical lesion. This is due to a common blood supply of the adjacent vertebra. An exam question, why it is paradiscal. The other types are central, anterior, and posterior. We will have a picture of this also. Now, what are the pathogenesis when you write the answer? Infection leads to hyperemia and osteoporosis, leads to osseous destruction, which takes place by bone lysis. There is further softening of the bone. There is mechanical effects due to gravity and muscle action, which leads to compression, collapse, and deformity. So this is the flow chart which you have to write in your answer when you answer the question of one line answer to your pathogenesis. Now, the disc is primarily not involved in TB, in the tuberculosis of the spine. Remember, it is affected secondary. We know that disc is avascular, so we know that there is no primary damage. It's always secondary. Why? Because we know that the nutrition of the disc space is via the end plates. We have two masters in the faculty who are among the authors of this paper, landmark paper from Ganga Hospital, Coimbatore. So we know that the same mechanism affects here too. There are two histopathological pictures. The granulomatous inflammation type, where you get a classical granulation tissue. Second is a caseous type with abscesses and sinus formation. Only two types for us to remember to write the answer. The sites which we mentioned, the most common paradiscal type, then the central type, the anterior type, the posterior element type, and the epidural type. Now, what is epidural type? That is the so-called spinal tumor syndrome. We'll discuss that. So remember these things to write your answer in the exam. 5 common sites of tuberculosis of the spine. Now, this is the region-wide distribution. This is from Professor Tully's study. It might change or it might be different today with the more data available. The most common being thoracic, followed by lumbar, followed by thoracolumbar, cervical, and cervicodorsal. Per se, the cervicodorsal is CD junction is not so common, but again, now these data might not be true. Now, how do we come to a diagnosis? Because they might either present with the disease or with a complication. What is the complication? There are only two complications of TB spine. One is deficit, second is deformity. So they might present early in the disease when they'll come to you with symptoms of the disease. What are the symptoms of the disease? Might be pain, which might be insidious onset, continuous, may or may not be associated with muscle spasm, or they might have symptoms of constitutional symptoms like fever, malaise, loss of weight, loss of appetite. Remember, these are nowhere specific, are nowhere sensitive. So you should not think that they are not there is not likely. 30% of them can present with deficits, with neurologic complications. So remember again, this is from Professor Tully's data. Now, the second complication they can come with is a deformity. These are two complications. One is they can present with the disease or they can present with the complication. What are the complications? One is the deficit, that is paralysis or paraparesis, or they can come with deformity. We saw the paraparesis, now they will see deformity. What are the type of deformity? The exam answer, knuckle gibbous kyphus. So what is a knuckle? When there is a one level involvement. What is a gibbous? When there is two level involvement. What is a kyphus? Anything more than two level involvement. So for an exam, most likely we might see the third type, out of which there are two types of kyphus. One is an angular kyphus, it's a globular kyphus. Quite self-explanatory. Or they might present with cold abscesses. These are the presentations of which they come with deformity. Now, why do you, again an exam answer, why do you get a deficit in tuberculosis spine? Due to inflammatory edema, there is abscess formation, sequestration, there might be vertebral dislocation or subluxation, there might be end arthritis of the spinal cord vessels, and spinal tumor syndrome, or because of the deformity. Now, what is the spinal tumor syndrome? Was described earlier, the pre-MRI era, where the patient comes to the ER or to the clinic with a neurodeficit and the X-ray is normal. There is no lysis or even a CT is normal. Today, it is not the case because we will have an MRI done, which will show a epidural granuloma or epidural mass. So earlier time, it was thought to be due to a tumor. Today, we know it is due to a tuberculoma or because of a mass. So that's spinal tumor syndrome, or could be because of deformity, wherein there is internal deformity pressing on the cord and that causing the deficit. So none of them is very clear what is what, but these all can happen as a singular event or as a multiple event. Now, the deficit. Well, there are two broad different types of deficit historically. One is the early onset paraparesis or the late onset paraparesis. Now, what is the essential difference? So, as regarding the time locus of origin, an early onset happens within 2 years of the disease, and a late onset happens after 2 years of the disease. Now, what is the difference? In the early onset, you get the deficit because of the disease, like in active disease, inflammation, edema, abscess, caseous formation, all what we discussed right now. Whereas in a late onset, you get the deficit because of mechanical problems, because of stretching of the cord over the internal gibbous, myelomalacia, gliosis of the cord, and all these things. So this is the reason why you get a late onset paraparesis. Now, per se, the results of late onset paraparesis are not as fruitful of treatment like the early onset. Even the treatment differs vastly surgically. Now we know that we will get all these investigations done. Our routine hemogram, you might have a raised CRP, SR, CBC picture might be normal, or you can even see lymphocytosis. Today, the genetic diagnostics are the mainstay. You have to have those gene expert studies done. Today, it's more or less very easily available and not very expensive in your diagnosis. They are very sensitive and very specific to the tune of 95 to 98%, which is a large number. And the mainstay is tissue diagnosis, culture of the body fluid or tissue. Now, all these rare presentations of TB of the spine, they can come with a spinal tumor syndrome. We discussed it. You can have a pseudo hip flexion deformity. How? With a psoas sepsis presenting a psoas sepsis because of a TB of the lumbar spine, presenting as a hip flexion deformity or a lump in abdomen. These all are also presentation because of a cold abscess. These all are atypical presentations of TB of the spine. Now, X-ray, MRI, plus or ultrasound, plus or minus CT guided biopsy. Out of which the last part it needs explanation. X-ray, what do we see when X-ray? We know that it's commonly a paradiscal lesion. The disc space is preserved up to the late in the disease. Now, when do you see a damage in the X-ray? Classically, when 40% of the calcium content is lost, which might lag 3 to 5 months from the onset of disease. Why do you see disc space reduction late in the disease? Because of atrophy of the disc, because of reasons we discussed earlier, or prolapse of the disc into the necrotic tissue. That's why we might get a decrease in the disc space. And the classical paravertebral shadows. Now that needs explanation. Depending upon which part of the spine is involved, we might have different kind of shadows. Again, exam question: prevertebral shadow in cervical spine, inverted V in the cervical spine, mediastinal widening. So in the thoracic spine TB, psoas shadow loss or widening of the psoas shadow in the lumbar TB, or you might see the deformity like kyphosis, scoliosis, or even vertebraplantar in children. Now, this is an X-ray of the cervical spine. You can see decrease in the disc space in this picture. There is kyphosis. You can see this increased prevertebral shadow. We all know the standard landmarks. And this is a TB of the thoracic spine, the classical bird's nest abscess. Look over this. You can see my pointer. So this is a bird's nest abscess, bilateral shadow. This is again suggestive of spondylodiscitis. Another picture where you see in the deformity quite obvious, you can see the deformity. So these are the obvious things you see in an X-ray. Now the classical question: can you differentiate on an MRI between tuberculous and pyogenic? The answer is you can, but you should not, because by definition, radiologic diagnosis is spondylodiscitis. Query TB, query pyogenic. The ultimate diagnosis is histopathologic or bacteriologic. So these are the findings which you might see in case of tuberculosis versus pyogenic. I would give the PowerPoint to Dr. Thomas. He can share it for you. Remember the levels of involvement, the kind of abscess, all these are classic features. Again, this is one picture which shows all the differentials: brucellar spondylodiscitis, fungal spondylodiscitis, pyogenic spondylodiscitis with tuberculous spondylodiscitis. So this picture tells you the classical features, how you can differentiate one, out of which remember one thing: ascending subligamentous abscess. I repeat, ascending subligamentous abscess under the ALL is kind of pointer towards a tuberculous spondylodiscitis. Multi-level involvement, ascending subligamentous abscess. Again, you cannot harp on it. It should be supported by a tissue diagnosis. Now, how do you make a diagnosis? By the clinical presentation, by the X-ray and imaging finding, bacteriology and histopathology. Today, this too is the hallmark or the mainstay of diagnosis. There are people saying that tuberculosis of the spine is a bacteriologic diagnosis, not histopathology. Why? You might have situations where you don't find the classical casations in your histobiopsy report, but your gene expert and culture might turn positive. So I trust on both of these to come to a diagnosis. I got kind of 90% bacterial diagnosis and 60% histopathology diagnosis. Biopsy. So today purists say that it is a must in a case of TB of the spine. Once you have a biopsy, your choice of access: CT guided, transpedicular, ultrasound guided. It's based on your center, your expertise. Once you have your tissue, you should send it for a gene expert or the PCR assay. Should serve for culture and drug sensitivity for pyogenic, tuberculous, fungal, must, plus histopathology. So this 5 things has to be sent from the tissue what you get. Now the question is biopsy mandatory? The answer is yes, with a clause. Why? Because you can pick up these non-TB infection, you can pick up resistant TB because you send for drug sensitivity. You have to document your diagnosis, and also you can safely go ahead if you have a medical legal issue, because you might have a patient who develops a drug induced hepatitis, goes into an issue, and can say that you gave me a ATD for a non-diagnosed disease and I learned up the problem. So it's very important there. Now let me put a clause here. As per the index guidelines, again I'm putting a clause here, you can go to this. The index guideline says that you may start a patient in an endemic region with ATT without a tissue diagnosis, but the risk and benefit of training biopsy must be considered. Again, this is an index guideline, so I can point out you to this. So this is again for an exam answer. If your examiner asks you, do you always have to go ahead with a tissue diagnosis to start TB? I would say ideally yes, but if he's saying no, why do you want to do it? You can quote this article. This is the index guidelines for treatment of extrapulmonary tuberculosis in India by the WHO as well as the Ministry of Health and Family Welfare. It's a free download. You can just search over. The last revision came in 2016, which says that you can go ahead, but ideally no. You should, whenever possible, try to have tissue diagnosis. So we end up with two primary problems. One is deformity, more or less a kyphosis. Second is deficit. Now, like a good doctor, when you treat a disease, you want to predict it. Can you predict it? The answer is yes. Professor Rajshekharan has described this SPINET risk signs, which are very useful in predicting your deformity. Now, mind it, Professor described this for pediatric tuberculosis. Pediatric. They are not essentially applicable in adults. So what are they? It is facetal dislocation, retropulsion of the fragment into the canal, lateral translation of an AP X-ray, and toppling over. Remember, all these 4 features are seen on an X-ray. On an X-ray. So these are features, if seen early in disease, is very likely to tell you that your child will end up with a significant deformity and you have to prevent it. We discussed that the idea today is to prevent deformity than treat the disease. Now, can you predict a neurodeficit? Now, this is information from multiple sources and unpublished literature. If this is based on an MRI, if there is more than 1/3 canal compromise, more than 20-degree kyphosis, more than 1/3 vertebral loss, and there's absent CSF sleeve or circumferential compression, these are features which suggest that your patient can develop neurodeficit. Again, this is not yet proved on a multi-center trial, but you can keep this in mind when you start treatment of your patients non-surgically or surgically. Now, what is the mechanism of deformity? You have destruction of your body, progressive collapse, which leads to deformity. And this also depends upon the area which is affected, depends on the bone quality, the potential of growth, and the spinal biomechanics. Now, why do you get a kyphosis? Because of spreading infection, there is shortening of the anterior column, there is tethered soft tissue because of disease and treatment, there is persistent posterior growth. What happens because of kyphosis? You might have impaired pulmonary function, is mechanically unsound. The kyphosis might lead to adjacent segment disease degeneration. What are the DDs of, the DD of deformity? Pyogenic, brucella, Schurman's, most common cause of the kyphosis differentials. Now, the treatment. What are the methods of non-surgical treatment? Bed rest and brace was used earlier. ATT, prolonged than standard 6 months therapy. Because why 6 months? We know that today or most of the pulmonary TB is treated with 6 months of ATT. Now, what are the methods of non-surgical treatment? You can have orthosis, which lead to immobilization. Again, a lot of confusion and discussions regarding the duration of ATT, type of ATT, etc. But for an exam, we have to give a definite answer. Now, what can help you give the answer? It is the index guidelines for treatment of extrapulmonary TB. Based on this, it's been stated categorically that you have to treat the patient for 12 months minimum, out of which 2 months has to be with HREEZ, the four drug therapy, that is INH, rifampicin, ethambutol, pyrazinamide, no doubt. The remaining 10 months has to be with three drugs. We classically treat pulmonary TB with two drugs, but a spinal TB has to be treated with three drugs for 10 months. So 12 months of treatment is mandatory as per index guidelines. The many centers having different protocol, but this has to be continued for at least 18 months on a case by case basis. What is this case by case basis? Having a repeat imaging done like an MRI after 6 months or 9 months, and then decide how long to continue the ATT. Now, why is ethambutol added? When we were classically treating them with INH and rifampicin, why did the third drug get added in this extended therapy? The reason was that there was 20% incidence of INH resistance. Remember, among all the anti-TB drugs, the most potent one is isoniazid. But 20% incidence of INH resistance, this was from Professor Anil Jain's talk, where he gave this data. And that again, two types of INH resistance, low level resistance and high level resistance. Now, in the low level resistance, higher dose of, we classically give INH at 5 mg per kg per day. This needed higher dose of 15 mg per kg per day. This is the reason why INS got added into these persistence therapy for 12 months as per the index guidelines. Now, coming to the surgical indications, what are the indications for surgery? Progressive neurodeficit, no response, clinical, radiologic, or both to conservative management, minimal deficit, persistent after therapy, large abscesses causing compressive effect, when there are spine at risk signs, and when there is involvement of multiple vertebrae which can lead to deformity. These are textbook indications. Now, what are the surgical goals? You might or might need decompression. You might or might not need deformity correction. You always need fusion, and you need early mobilization. So point one, number and two can be on a case by case basis, but three and four has to be there. You have to achieve solid fusion. You have to allow early mobilization. Now, what are the options? You can just drain the abscess. You can decompress the cord. You have to correct the deformity and achieve fusion. This can happen in unison or in combination. Now, just one note that about the use of pedicle screws or instrumentation. Without doubt, it has been proved that you can safely use instruments in spinal TB, both titanium as well as stainless steel. Titanium is more ideal because of less biofilm formation, and it's MRI compatible. I don't use steel at all in any of my tubercular spines because of the I might have to image them post-op. Rather, I always image all my surgical cases to see the resolution. There is no role for an isolated laminectomy in today's TB spine because it's against the mechanics. Laminectomy is a destabilizing procedure. TB spine primarily is unstable because of disease. You are adding insult to injury by doing a laminectomy. It has to be done along with an instrumentation procedure. Now, how do you decompress? It could be from the front, it could be from the side, or it could be from the back. On a case-by-case basis, you can decide based on your axial MRI how you are going to decompress or what you're going to decompress. Now, this is the conundrum. Infection leads to instability. Instability leads to neural compression. That again leads to kyphosis. So it's a conundrum where you have to break in somewhere this whole cycle. We come to three essential type of kyphosis: a wet disease, a healed disease, or in children. Now what? So we deal our deformity, the kyphosis, two ways. It's wet or healed. If it is wet, you see that do you need a deformity correction or don't need a correction. If you did, you decide based on an anterior posterior or anterior alone or a posterior alone. This is a slide from my colleague, Dr. Abhay Nene. who's one of the authorities in TV spines. Or if you see in a heel disease, what you do, you want an internal gibectomy or you want a deformity correction. We'll see a case example of each. Now, in an active wet lesion, you can correct all this without much morbidity. How? Let's say a patient, a 16-year-old female who had ATT for 18 months after a tissue diagnosis, who developed significant back pain and presented with deformity with no neurodeficit. These were her picture on presentation to us. She had almost 52-degree kyphosis with nearly one total vertebral loss. You can see the MRI after 18 months of PTT still showing disease, and she was having significant pain. So we decided to go ahead, use the so-called the LECA approach or the lateral extracavitary approach. Why is this extracavitary? We did not open the pleura. The so-called costo-transectomy approach. We did a back and front job. This is the approach we used. And this is what we did. Went ahead, you can see, did a laminectomy, wide lateral approach, ligated root, and when we filled the anterior anterior column with the cage, shortened the column, and this were her ultimate picture. So we achieved the goal of surgery from the back. So you can do a back and front approach wherein you deal the wet lesion, you can correct the deformity, you can achieve stabilization, you can achieve all your goals from the back itself in a wet lesion ideally. And another patient who had 2 months of fever was treated for ATT for 1 month with for a lack of diagnosis, presented back pain, complained back pain after 2 months, and she came in with paraparesis. This where her X-rays. You can see a classical wet lesion. MRI, she's showing correction. If you look back, the X-ray showing deformity, MRI showing correction. Why? Because MRI is taken on supine position. It is opened up a bit. The X-ray is taken standing. Hence, you can see the deformity. This is what classical. The root to the front is to the back. We use these cages, and these are X-rays. Achieved all the goal: correction of deformity and stabilization and fusion with the same approach. Another patient presented with paraparesis onto the ER, difficulty in walking, 2 months of neck pain, and in the ER developed quadriparesis. This was his MRI. We thought that he's developing a vascular issue. Went in urgently, did a angiodebridement and a fusion with a cage without instrumentation, recovered eventually. Again, the last type, the deformity, which the late onset paraparesis or the deformity because of a heel disease. So typically what happens because of the mechanical problem or the progression of the disease, they start and they develop an internal gibbous, which leads to a deficit because of stretching of the cord, myelomalacia or gliosis. So wherein what do you treat? You have two things. You just do decompression, wherein you only treat the neurology, or you treat the neurology and the deformity based on a case by case basis. Very difficult to treat, wherein you can remove you can do it by an anterior approach where you just remove the part pressing on the cord. That is, do an internal gibectomy, which can be done from the front or from the back, or you have a case wherein you correct everything from the back. So this was a 69-year-old man who came to us with paraparesis of 6 months duration. He had history of tuberculosis spine at 30 years of age. When it was treated non-surgically. This was how he came to us. And he had a gibbous, sorry, this is not 50, this is just 69. This was the deformity wherein he came to us with paraparesis. So this was his MRI. We discussed the options, 3-level loss. So where I thought if I try to do everything from the back, or I try to do internal gibectomy or do any VCR kind of correction, I might cause a lot of problems because he was already had a sick cord, and for 30 years plus he was on the deformity. So we decided not to attempt any great correction. We would just do an internal gibectomy and treat his neurology by holding the deformity. So we did a back and front approach, did the back and did the front, and this was actually the CT after 6 months. So this is it. This is how we did an internal gibectomy from the front and wanted to hold it further to preventing further. So did a post instrumentation. Now, couple of atypical features. What is a paradoxical reaction? A patient with a proved tubercle of the spine on ATT getting better for a couple of months suddenly starts worsening. How it worsens? Patient wound dehiscence happens, or deficit comes in early, or pain sets in. The first thing we think that is that it is drug resistant TB, or something is wrong. So this, mind you, this is not drug resistant. This is paradoxical reactions. Now, how do you differentiate this from a suspected drug resistance? A suspected drug resistant patient fail to improve from on ATT, or they constantly deteriorate. There is no improvement until a second line therapy is started after proving drug resistance. Whereas in a paradoxical reaction, there is always an initial clinical improvement followed by worsening. You might have wound dehiscence, you might have slight developing of new onset weakness or pain. Usually this gets better with NSAID supportive treatment and often adding some steroids transiently. Remember that all worsening of disease after ATT does not mean it is MDR-TB. Please keep this in mind. The incidence is being reported from 1% to 6%. Next is MDR-TB. We should all remember what MDR-TB is. So by definition, we know that when the bacilli is resistant to INH and rifampicin, it is called MDR-TB. Two types. It could be a primary resistance when the patient did not ever have treatment for tuberculosis of the spine or elsewhere, where you gotten the tissue diagnosis which showed resistance, or an acquired resistance or a secondary resistance where patient was on treatment, then did not improve or started worsening, where you took a tissue diagnosis and then showed drug resistance. Why there is drug resistance? Because of single antibiotic therapy, erratic drug ingestion, suboptimal doses. These are all because of secondary resistance. Poor drug absorption, inadequate duration of treatment, inappropriate drug administration. These are all causes of secondary resistance. There are primary resistance because of the bacilli per se, bacilli mutation. Now, different types of definitions. Monoresistance, where you develop resistance to any of the five. Poly, when more than two. The classical MDR, when it is to INH and rifampicin. And XDR, or extended drug resistance, when you have INH, rifampicin, fluoroquinolone, and any of the injectable, where all these are present. It's called MDR, XDR, mono or poly resistance. Now, there are three types of drug resistance, or three types of MDR-TB. One is a presumptive drug resistance. Second is a proven drug resistance, wherein you have a tissue diagnosis which shows INH and drug resistance, INH and family resistance, or a clinical drug resistance, wherein the histology was correct, culture had no growth, and the molecule was indeterminate, the patient did not improve. Now, what is a presumptive drug resistance? You would started the patient, a culture positive case, where you started the patient on ATT for at least 4 to 5 months, and the patient failed to respond clinically and or on imaging, plus or minus development of new lesions and wound dehiscence. Remember, how to differentiate this from a paradoxical reaction? In that, the patient early gets better and then worsens. That's how you differentiate it from a presumptive drug resistance. Now, what is the line of action? You again have to prove your drug resistance by a gene expert. You have to use a bacteriologic method, not a histopathologic method. A bacteriology, especially molecular diagnostics, to prove this is the recommendation as per the government of India. Now, how do you treat them? It is not our cup of tea. Should be sent to a specialist. 6 drugs, intensive therapy, always just not to start at least one drug, always at least 2 or 4 are started, goes into up to 2 years and needs intensive monitoring, is very toxic and very expensive also. So to take home, TB spine is a medical disease. Early diagnosis and ETT is a key to management. No non-surgical therapy without appropriate imaging and tissue diagnosis. Look and be aware for the high risk signs. Please, there is no role for an isolated decompressive laminectomy. If surgery, please do a complete job. You have to follow all the principles. Instrumentation is safe in TB spine. Thank you, Dr. Thomas.
Thank you very much, Sanjit, for that very comprehensive talk. You covered all the points. There were a couple of questions, but I'm going to just put one question across to you just because we're slightly running out of time. How will you decide to end the treatment? Do you just go by duration of ATT, or do you go by clinical, imaging, laboratory, or all of them?
Yeah. So, Thomas, there are two things when I answer this question.
Sure.
As per the index guidelines, you should prove that it is resolved by imaging, right? So in my practice, I have every patient, when I stop ATT, I have an MRI done. And I give for 12 months of ATT. At stopping of ATT, I always take an MRI and see for decrease in abscess as well as fat conversion on the vertebral body to make sure that it is healed. So I deal with imaging, not possible in a major setting, but ideally you have to stop it once the patient gets better and all those things we discuss. Before stopping, you have to have an MRI imaging possible today. And before that, let me tell you, don't get an MRI done at 3 months. If you get an MRI done at 3 months, it's proved beyond doubt that abscess increases. It looks more worse than your primary imaging. Don't get an MRI done at 3 months. The earliest time is at least 5 to 6 months. Unless there is a fresh onset development like paraparesis, or fresh onset paraplegia or weakening, where you have to have an early imaging, with keeping in mind that don't based on the abscesses to make a diagnosis. Say you have treatment where you have a spinal tumor syndrome picture or you're a vascular cause, you can have an MRI there, but not to look at the abscess.
Thank you very much, Ranjit, and thank you very much for your excellent lecture. And with that, we come to the last lecture for the day. I invite Dr. Naresh Babu to give his lecture on scoliosis.
Thanks, Thomas. Hope slides are visible.
Yes, slides are visible. Thanks.
Yeah. So outset, I would like to congratulate you for doing this wonderful work for so many years, continuously and without any break. So my talk is on understanding scoliosis. I'll just keep it quite simple for this. Okay. This is what we see in our intrauterine life. The spine is a continuous C-shaped structure, but as the patient, the baby gets developed into a full adult, you will develop the curves into cervical lordosis, thoracic kyphosis, and lumbar lordosis. But how does this happen? These natural curves will usually happen when the patient, when you start walking, when you get that head holding, the cervical lordosis develops. When the baby starts walking, the lumbar lordosis develops, and they maintain forever. But it's so when you look from the back, you are supposed to have the entire spine straight without any deviation. Similarly, when the spine is looked from the side, should have a lumbar lordosis, thoracic kyphosis, and cervical lordosis. So it's not quite uncommon to see patients presenting with these kind of deformities when there is the spine is crooked, bends to one side, and one shoulder is elevated, one hip is elevated, and the trunk is shifted. And also you can see these patients coming with kyphosis deformity of the spine, which is a anterior deviation of the spine, and also the rib humps, which are quite significant and disfiguring. So because of the rotation of the ribs, vertebral bodies, the ribs gets rotated and the patients develop these kind of rib deformities. So these are how these patients look very sick, and then that's how they are. So this happens in all the age groups, from kids to adults, and can happen with the different forms of the disease underlying. So one should remember that scoliosis is not a disease per se. Whenever you see a scoliosis, that is a structural change in the spine. Should look for manifestations of underlying condition. It is quite possible that these can be a manifestation of underlying condition. So these are classified when you don't have any reason to document the underlying condition. These deformities were called as a idiopathic scoliosis. So this can be divided into different forms depending on the time of onset or age of onset. The infantile, juvenile and adolescent deformities, and also now we have the other entity which is a idiopathic adult spinal deformity, which is a neglected adolescent deformity basing on the age of onset. When coming to the clinical examination, so the head is not centered. That is what we look for the initial appearance from the back, and one shoulder blade is elevated, and you will see unequal gap between the arms and the trunk. These needs to be documented when you get these patients as spotters, and one hip is more prominent than the other hip, and you can see the spine deviated to one side. That's how the scoliosis looks. So the best way of screening this scoliosis is to do Adams forward bending test. This is a very important test and it's commonly asked question. How do you this when the patient bends forward, the spinal deformity gets revealed, and one side of the rib cage looks to be quite prominent compared to the other side. So that's how we screen these patients, and these can be measured as well with scoliometers. The amount of rib hump deformity, the angle of lumbar hump deformity can be lumbar muscular hump deformity can be easily identified and measured and documented with the scoliometers, which is just a angular meter where we can have the angles measured and documented with the repeated follow-ups. These can be measured quite easily. So beware of these clinical markers. When you see a tuft of hair on the back, these coffee-eyelid spots, and the dimple on the back, and some kind of ptosis or eyelid deformities or neurofibrinosus features and morphonoid features, these patients tend to have this kind of deformity. One should differentiate these with the sciatic list, which is very quite common in the patients with the degenerative pathologies. Whenever there is an acute disc prolapse, the patients also tend to rotate to tend to deviate to one side. That's called sciatic list. So how do you differentiate the sciatic list from the scoliosis? The scoliosis invariably will find the vertebral bodies being rotated, but in the sciatic list, it's just a truncal shift onto the one side without any rotation of the vertebral bodies. And also many times we may notice these kind of deformities in the patients with the limb length discrepancies. You can see this patient when the limb length discrepancy is corrected with foot rise, the knees are leveled and then the pelvis gets leveled up and the deformity disappears. So these things are also very important, that seeing the just spinal deformity doesn't suffice. And these patients can have a major neurological problems with the formation of serines in the spinal cord. This needs to be picked up. And subtle forms of these patients with scoliosis can be muscular dystrophies can be missed in the early period. Beware of these things and then try to pick them up rather than thinking them as deformed spines, and operating will be a little problematic in the future. So the best way to pick these kids to do a Gower sign. When the patients are unable to get up without even a single stretch, when they do it in a tripod sign or Gower sign, this indicates a subtle amount of muscular weakness, and these patients are quite problematic if you operate on them thinking that these patients are idiopathic scoliosis patients. They present with the natural disease process few years later. Then we have burned our fingers. These long C-shaped curves and the curves with which are located at thoracolumbar level, and then very sharp angular curves, we should always suspect that this is not an idiopathic scoliosis. These patients can be a kind of There is some other underlying problem. These are not idiopathic curves. They tend to progress quite rapid, and you need to investigate for them for the spinal cord and also for the muscular things. And also the patients with oblique takeoff, sudden oblique takeoff, and then penciling of these ribs, and sometimes widening of the spinal canal. They also suggest some kind of underlying neurological issues. Fusion of the vertebral bodies, and then C-shaped curve, lazy C-shaped curves, widened interpedicular distance. This is synostosis of the ribs. So these are the subtle signs of involvement of formation defects, and these patients are known to have high chance of intraspinal anomalies as well. We need to pick them up before operating them or just observing them under conservative care. These patients also have a natural curve. When untreated curves, they tend to rapidly progress till the patient gets the skeletal maturity. And the patients with quadrilateral hemivertebras, where the vertebra is formed only in particular angle, only in the one corner, they can develop into scoliosis or sometimes into aggressive kyphosis. Given the situation in the scoliosis and kyphosis, the scoliosis can progress to 100 degrees or 110 degrees, but that doesn't cause neurological issues because the spine gets accommodated within the scoliotic deformity. But the kyphosis, progressive kyphosis, is the one which is very dangerous. And if you see patients who are on kyphosis, we need to very closely monitor them, and the patients can develop early neurological symptoms because the kyphotic fragment will, it's like an internal gibbous will compass on the spinal cord, leading onto neurological deficits. But doesn't happen with the scoliosis because it's only the lateral deviation of curve. Even with the increase, that doesn't happen. So this happens in different forms. So how do you decide about the treatments? There are a few basic things which we need to remember. The curves less than 30 degrees at the time of bony maturity are unlikely to progress further. That is one rule which we all need to understand. Curves greater than 50 degrees at the maturity, they tend to progress 1 to 2 degrees per year. So these are quite clear. If less than 30 at the skeletal maturity, you don't need to worry, they don't progress. If more than 50 at the skeletal maturity, they tend to progress 1 degree per year. But 1 degree is not much, but with after 10 years or 20 years after skeletal maturity, that will add up to 20 to 30 degrees. That is a significant deformity. So the thing you need to remember is 19% of the females with curves greater than 40 have significant psychological illnesses, and life-threatening effects of the scoliosis and pulmonary function will happen only after 100 degrees. Then they reach near to 100 degrees. This tend to happen. The recommended guidelines for treatment or referral guidelines are very important to understand, because this is what, if you are not a scoliosis surgeon operating, we should be at least knowing what needs to be done for these patients. So the curve is less than 20 degrees, the 10 to 19 degrees. The risk grade is less, that means the patient is very young. So we need to follow them up every 6 months and observe. If it is less than 20 degrees, but the risk grade is 2 to 4. So every month follow up and observe the same. If it is 20 to 30 degrees and the patient is very young, so we need to brace them up after 25 degrees of deformity. 20 to 30 degrees in little bigger kids, we can observe them because they are close to reaching the observe and brace them because they are nearing to the skeletal maturity. So up to 40 degrees in less than one risser, we need to refer them because they need a expert opinion. 20 to 40 degrees in 2 to 4 also need to be referred. They may need brace, and more than 40 degrees from 0 to 4, any amount of skeletal maturity greater than 40 degrees needs a referral, and they may need surgical correction for this. So these surgical corrections, the principles are like when you have a big girl, grown-up girl, and there is a big curve, there is no doubt at all, but it all happens when you have a big curve in small kids. Then how to manage these curves is also important. Large curve in a small curves. So we can also have a large curve in not very small girl. They need to be treated separately based on the philosophies. But these rules doesn't apply when the patient have got these segmental deformities or formation defects, because they tend to behave completely differently, and you can't apply the rules of adolescent idiopathic scoliosis rules in the patients with congenital scoliosis where there is a segmentation or formation defects. The most problematic kind of formation defect is a quadrilateral hemivertebra. So this can cause scoliosis in the coronal plane and also can cause kyphosis in the sagittal plane. We need to be very careful about these things. And these patients with congenital fusion and a bony bar which is fused, these segments of the spine, they don't tend to grow. Mostly they develop into severe kyphosis. Coming to the radiological analysis of these patients, there are a few terms which are very important to know. So end vertebra is the end of the curve, the proximal and distal end vertebra. The curve, the deformity curve extends between the two end vertebrae. So you need to very specifically identify this end vertebra. So how do you identify this end vertebra? Whenever the curve is shifting from one concave to convexity, the change of angle is where that happens is the end vertebra. So if this patient, you can see it's from the T6 to T12 is the end vertebra. That is the main curve. Apical vertebra is the one which is maximally deviated from the center. If you draw a center line, the T9 is the one which has deviated quite significantly. That is the apical vertebra. The neutral vertebra is the one which doesn't rotate much. That's the proximal most vertebra which has no rotation is a neutral vertebra. The stable vertebra is different. The stable vertebral concept is when you are trying to correct the deformity, you need to catch the stable vertebra and you need to know about the stable vertebra. This is the vertebra which is bisected by the central sacral vertical line. So this patient, you can see this stable vertebra is extended all the way up, and that means the lumbar curve is quite flexible. These patients can be easily managed with the selective thoracic correction. The few steps of the deformity correction, you need to expose the spine. Once the spine is exposed, the pedicle screws were put depending on the strategy what you plan, and these are connected with a rod so that the deformity gets corrected. When you anticipate a lot of cosmetic deformity arising from the derotated or deformed vertebrae, which are leading to rib deformities, thoracoplasty can be done, meaning the angles of the vertebrae, valence of the ribs which are sharply projecting up can be resected. The same bone can be used for fusion. So this girl had just the deformity correction resulting in a quite decent sagittal and coronal profiles without needing a thoracoplasty because of the powerful instrumentations used for derotate the spine. The similar things here, so you can have a nice amount of correction. These surgeries can also be done with the anterior approach when you are planning for a selective thoracic correction, and this can be even performed with the small holes from the side by thoracoscopy. You can see the 3 portals on the right side of the patient, just at the level of axilla. There are 3 portals through which this surgery was performed with that brings up to the true cosmetic nature of the correction. So rib hump deformity is the one which is most disfiguring, and the patients are quite concerned about this rib hump deformity. So the procedure doing thoracoplasty is the same as you can use the same incision through which the ribs were exposed, and subperiostally the part of the ribs which are contributing to the deformities are resected. So you can see these 3 ribs were resected in this patient to get the cosmetic correction. These were the segments of the ribs which were resected. And the patient is small and the curve is very big. You can either decide to sacrifice the height, or you can take a decision that the patient can have a permanent fusion when the patient is even quite young. But this becomes a problem when the patient is very small. Then you need to decide between what should we have? Should we have a short and straight spine or a long crooked spine? So why are we calling this as a short and straight spine? Because when the patient presents to you at this age, when she is very small, if you correct the spine and fix the spine will become straight, but the thoracic spine doesn't grow because you have already fixed the spine. Patient can only grow on the legs or the unfused segment of the spine. So the patient can have a very straight spine, but she will end up being very short. If you leave the deformity without fusing, then you will end up with a long crooked spine, but the patient will be little taller, but the spine is very crooked. So to address these two things, there comes the role of fusionless growth rod corrections, wherein the deformity is only contained but not permanently fixed. And this needs to be, so this is a kind of a procedure where growth rods are used to hold the deformity and also lengthen the spine. It can be done either with a single long incision submuscularly or two small incisions, and these are connected with a rod with a clamp. These clamps can be tightened to one side and then lengthened over a period of time. So this is a small example where we have two separate small incisions at the proximal and distal stable vertebrae. Pedicle screws were put and this rod is passed submuscularly, and this is the clamp which connects the two rods, and these rods can be lengthened at every 6 months. So you need to maintain a few things whenever you want to use this kind of construct. The rod which is intended to slide should be straight, and you should maintain the sagittal profile of the spine. This is one of the example where this kind of growing rod construct was put and was used as a single rod, or you can use a dual rod and correct the deformity. With every lengthening, patient will get some height and deformity will be contained. Until the patient reaches the skeletal maturity, this can be done. At the time of patient graduates into fully skeletal mature girl, the final fusion can be attempted, or if the patient develops autofusion because of the repeated lengthenings, we can avoid the surgery altogether at that time. So to avoid this regular repeated lengthenings, this kind of procedure, which is a Schiller procedure, was used, wherein the the apical part of the curve is contained, the distal part of the curve is also fused, and then top levels were kept open. The two ends are open, and then the center is corrected. So this will allow the spine to lengthen over a period without doing that. So we do with the same construct with little modification. The two screws and the center, and use a rod, and these rods tend to grow over a period of time. So this is how these patients are managed. So nowadays we have the new developments in this field where to avoid repeated lengthenings, the magnetic growing rods can be used, where the initial surgery was done under anesthesia. The screws were put, the instrumentals were applied. The repeated lengthenings were done under without anesthesia. Then you need to open the deformity, use a external device which can be used to lengthen the rod without much deformity. So these are the few other recent advances which are happening in the field of scoliosis surgery. I think with this I'll just stop. This is quite good enough for a resident student to understand. It is a simple overview of deformity corrections. Thank you, Thomas. Hope that is useful.
Yes, thank you very much, Naresh, for that excellent lecture. You've covered all the points of early onset scoliosis and adolescent scoliosis. Just a question for you. Somebody wanted to know, what is the minimum age at which you can do scoliosis surgery?
So what kind of, if it is growing rods, we can do it from 3 years onwards. So it's only so one needs to understand the philosophy of surgery. Putting pedicle screws can be done, the vertebral body can accommodate pedicle screws from 3 years onwards. That's the time when they reach the adult size. That is quite safe to use, but you can't fuse them if you are trying to lengthen them because it is a idiopathic infantile scoliosis. So if you are operating on a congenital scoliosis where you are resecting the hemivertebra, you can safely put the screws and then fuse the apical segment, and the patient you can elevate to grow. So it all depends on which scoliosis surgery we are using, which we are doing.
Thank you, Naresh. And one more question was, can severe scoliosis be fatal?
Yeah, severe scoliosis, if it is more than 100 degrees, that can cause cardiac issues and pulmonary issues leading to carpulmonary, and patient can fail to thrive. And also that is about like neglected idiopathic adolescent scoliosis reaching up to 100 degrees and above. The other variety of things which are quite incompatible with sustaining life are the ones which we call them as early onset scoliosis, where there is a thoracic insufficiency syndrome, where the deformity sets in quite early in the age, and that doesn't allow the pulmonary alveoli to multiply and develop, and these patients will end up in severe respiratory distress syndromes. There will be very short window of opportunity for them to operate, but that time the patients will be quite young. So if you fail to operate at a particular time, they end up with the severe respiratory problems. So thoracic outlets, thoracic insufficiency syndrome in the kids, and then neglected adult deformities which are more than 100 degrees at adolescent age are life-threatening.
Thank you, Naresh. I think we'll stop the questions for the time being. We've finished our allotted 2 hour slot. So I'd like to thank the audience, all those who logged in to join us for the session. Thank you very much for being with us. If you have more questions, you can always WhatsApp them to me. My number is 9980-400-858, and we can keep the conversation going. A big thanks to all the faculty members, Dr. Naresh Babu, Dr. Ranjit Unikrishnan, and Dr. Leela Prasad. Thank you very much for taking your time off your busy schedules and giving those excellent lectures. Thank you very much. I hope to see you in Bangalore when we start our face-to-face sessions of Bone School also.
Sure.
Thank
Sure,
you.
Thomas.
A big thanks to OrthoTV, Dr. Ashok and Dr. Neeraj. Without your broadcasting capabilities, I don't think we'd reach the wide audience that we get. Thank you very much. And with that, we come to the end of the session. Thank you very much, gentlemen, and we will log off. Thank you.
Thanks, Thomas. I think we need. I only hope that you will get enough strength to continue this forever.
Yeah, sure. Really
Thanks.
good job.
Continue it forever as long as your time permits. I know how much time it takes off your busy practice, but your commitment to PG teaching, I know you from teaching days. It's wonderful.
Yeah.
A big applause for you.
Thank you. Thanks, Naresh.
Keep
Thank you.
Thanks,
doing
Thomas.
Thanks, Ranjit. Thank you. Thank you, Leela.
Yeah, thanks.
Thanks. So shall we log off, gentlemen?
Yeah.
Thank you. Thank you very much.
So, patient